touch of a precious child and know a mother's love. It's funny how it's the little things in life that mean the most, not where you live, what you drive, or the price tag on your clothes.
Muy buenas tardes a todos. Bienvenidos al seminario web titulado Metabolic Patient Management During a Pandemic, dictado por el Dr. Marshall Summer. Esta instancia ha sido organizada por la Organización Latinoamericana de Errores Innatos del Metabolismo y Pesquisa Neonatal y por el Laboratorio de Enfermedades Metabólicas del Instituto de Nutrición y Tecnología de los Alimentos de la Universidad de Chile. La conferencia durará 30 minutos y luego tendremos 20 minutos para resolver sus dudas. Los invitamos a realizar sus preguntas mediante la opción Preguntas y Respuestas de la plataforma Zoom o a través del Facebook de SLEIMPN o de INTA-Universidad. Esta instancia estará moderada por el Dr. José Abdenur, quien es el jefe de División de Enfermedades Metabólicas y director del Laboratorio Metabólico en el Children's Hospital of Orange County, California, Estados Unidos. Además, el Dr. Abdenur es profesor clínico asociado en la Universidad de California en Irvine, director del programa de Genética Bioquímica Médica y expresidente de la Sociedad Latinoamericana de Errores Innatos del Metabolismo y Pesquisa Neonatal. Doctor Abdenur, le doy el pase para que inicie nuestro seminario web.
Did we lose Jose?
Dr. Abdenur? Are you here?
Ahora vamos de nuevo.
Ahí está ya al aire, puede comentarnos lo siguiente para poder comenzar con nuestro seminario de web.
Bueno, muchísimas gracias por la presentación y muy buenas tardes a todos. Como es sabido, la pandemia ha desencadenado la necesidad de implementar protocolos de distanciamiento, lo que ha dado lugar a un cambio drástico en todas las actividades, incluyendo las actividades académicas y científicas. A consecuencia, el Congreso de SLEIMPN de nuestra sociedad, que estaba previsto a realizarse en la República Dominicana para este año, bajo la presidencia de la doctora Seila Pérez de Ferrán, debió ser reprogramado para el año 2022. Conscientes de la necesidad de mantener una actividad académica durante este largo plazo, la directiva de la sociedad, así como los comités científicos que habían sido conformados para el mencionado congreso, han programado un ciclo de seminarios vía web. En el día de hoy presentamos el primer seminario de esta serie que hemos realizado juntamente con el INTA de Chile, quienes han aportado toda su experiencia y soporte técnico, y desde ya a todos ellos va nuestro agradecimiento. Hemos decidido que sería muy pertinente que los primeros temas a abordar en esta serie fueran relacionados a la pandemia, que de una manera u otra nos afecta a todos. Así es que el tema de hoy es Metabolic Patient Management During a Pandemic. Cambiando al inglés, I have the pleasure now to introduce Dr. Marshall Summer. Marshall is the director of the Rare Disease Institute and chief of genetics and metabolism on the Margaret O'Malley Chair of Genetic Medicine at the Children's National Medical Center in Washington, D.C. in the United States. Marshall is professor of pediatrics at George Washington School of Medicine. He's a Tennessee person. He obtained his bachelor's in molecular biology at Vanderbilt and then medical degree at the University of Tennessee. continue then with medical training at Vanderbilt, as well as generics postdoctoral training in the same institution. He's very well known in our community internationally. He has many publications, more than 150 peer-reviewed publications, and difficult to count number of international and national invited talks. He has many different leadership roles. I would like to highlight that he's the chairman of the board of the National Organization for Rare Disorders, or NORD, an institution that we all know represents all the family organizations for rare disorders. He's also the past president of the Society for Inherited Metabolic Disorders. Marshall is probably the scientist that outside Latin America has given more talks at our society meetings. He became a member of our society actually in 2019, so he's a part of our society as well. And most important, I have the pleasure to say that he's a friend who is always willing to help. With that, I give it to Marshall.
Jose, that's a tough introduction to top. All right, let me share my screen here. Okay. Are we coming through okay? Yes?
Yes.
Excellent. So first off, it is an honor and a pleasure to address you. I send the greetings of my team here in Washington, D.C. As you know from past meetings, I believe the last one was in Buenos Aires. It is always one of our highlights of the year when we can come and visit our colleagues in Latin America, and several of my doctors are from the region as well too. So first off, I hope you are safe, you are well. I hope your families are safe and well also. This has been a most interesting time, but we've learned some very interesting things. And what I'd like to do is share some of those with you today. Interestingly enough, some of the lessons we learned about telemedicine, I actually learned first during some of my visits in Latin America. So I'm bringing home some of the things that you taught me. All right, let's get this going here. There we go. So telemedicine has been something that people have been talking about for many years. Some people have been trying it, some have not. In our community, though, it has always, to me, made a lot of sense. Our patients are medically fragile. They don't necessarily travel well. They have a lot of issues around coming into hospitals, being exposed to infections. So it's something we've been working for. In the US, actually, we've had more barriers to telemedicine than I think other folks have. Many of those things come back to our payer models and things like that. But suddenly we hit COVID-19. And there's an old Winston Churchill quote that I like a lot, but it basically says that never let a good crisis go to waste. And I would not wish the COVID crisis on anyone. There are many sad things that have happened, but it also forced us to try some new things. And so what I'd like to do is sort of share that with you. So we got a preview that this was coming back in February, and we'd had an active telemedicine program, but not a big one, for the last 2 or 3 years. But we flipped our entire clinical program to telemedicine in March 2020. 2 of the physicians, I was one and Dr. Deb Regier was the other one, saw all the patients that needed to be seen face-to-face. And then we saw over 1,500 patients by digital and remote, including our entire biochemical practice of 700 to 800 patients. One of the things we have found from surveying our families is the patient satisfaction rate was very high, but I also have some very interesting data to share with you about what we found. So this slide sort of shows where we were. We were doing a trickle of telemedicine, and then starting in March, we began averaging 400 to 500 visits per month, and that has continued for June and July as well too. what were some of the things we noticed and why did we want to deploy this way? Well, one thing we thought would happen with telemedicine is it would improve access to care. When patients are coming in a very structured clinical setting, the wait times can often be quite long, both in the facility, which is not good for patients, but also just to get the appointments. It also allowed us to go in and address simple issues. All of us have metabolic patients who we just need to check in on. But if we schedule a formal visit at our facility, that takes a large block of time. People are transported back and forth. And so either we don't do those simple follow-ups or they become rather burdensome for the family. So we found that we could go in very quickly to a home, see how a patient was doing, address an issue, see how the patient looked. And we think there was some real benefit, and I'll talk about that data in a little bit. It also allowed us to save physical visits for patients that really had to be seen in person, ones where there was a physical exam issue, a blood drawing issue, an ill newborn screening patient where we knew there was high likelihood of admission. Some of the benefits for virtual home visit, we found our patients with behavioral issues such as autism, but also many of our biochem patients with behavioral issues were much more relaxed and much more comfortable being seen in the home. Now it's a trade-off. There are certain aspects of the physical examination you can't do, but overall we found it was a net plus seeing these patients at home. Our dietitians loved doing these virtual visits during the COVID pandemic because they would actually have the parents take the cameras and go to the refrigerator and look to see what was actually in stock, see what could be used, have the patient show us what they were eating for lunch or dinner. And so they could do those quick visits with the families. And we found that actually that was a big plus for us. Now, getting blood transported back and forth or blood spots, we were able to do, so we were able to monitor those patients. But for the dietitians, we think it was a big plus. Also, we were able to increase our frequency of visits. For the patients, some of the big benefits were if you had a patient, particularly one with severe neurologic issues, you did not have to transport them. So you did not have to take a patient in a wheelchair, put them in a van, drive them to the hospital, roll through the hospital, everything else. For our families with other children, it meant they didn't have to find childcare for the other kids. That actually reduced the family stress tremendously. It also improved our compliance with seeing the patients. And then also for those families, that fear of exposure to the illness. Our families were very clear. They did not want to come to the hospital unless they absolutely had to. So we really needed to find another way to see them. And for our families where both parents were working, it meant that a family or a parent did not have to take off from work, lose that income, risk their job security during a time when job security became very important for some folks. And then we did a combo. So some patients, when we needed to see them, we saw them, but others we kept at home. We also found for multi-specialty visits, this was really good. The Zoom wall, which we all have gotten used to, I think. I don't know if you remember an old United States TV show called The Brady Bunch, but our clinics often look like the intro from The Brady Bunch with all the little pictures of people. It was easy, though, to bring multiple providers in. It was more efficient in this regard. And for times when we needed translators, they could actually come into the screen, do their work, and then go on. So we found that it streamlined care. It also allowed us to expand reach. We found there were some areas during COVID where patients could not get to a physician. So we were able to reach into areas in the United States that did not have coverage for biochemical genetics and take care of patients from a distance. Also working with some of our international groups, we actually found these visits became better as we developed our capacities. So what happened as far as the patients we were seeing, things like that? Interestingly enough, we were supposed to see 4,500 patients during the COVID period. We actually saw 4,500 patients. What we found is that we had a large decrease in our no-show rate. The patients who did not make it to clinic normally are about 14 to 15%. That actually dropped down to about 8 to 9% in the COVID period. So we saw an actual increase in our patient volumes during this time. Our inpatients, and this is where I think this is important for our biochemical patients, we normally during this time of year would see about 736 patients. We actually only had to admit 600 patients. And this is data that had been consistent for a number of years. And we think there were two things going on. One, the patients sheltering at home were not being exposed to as many infectious agents as they normally would. And we found that our patients that were COVID positive really did not have a real big increase in burden of disease. We'll talk about that in just a second. The other thing, since we were able to monitor the patients more closely, the patients didn't have to come into the hospital to be seen as much. That also seemed to actually stabilize them a bit more. So we found better compliance. The PKU patients seem to be doing better with this. Our more severe patients, like our organic acidemias, urea cycle patients, we were actually able to measure at home. To manage at home. About the only thing we occasionally got uncomfortable with is diseases where hepatomegaly or liver enlargement was an issue. Obviously, that's very difficult to test at home. But there were a couple of cases where patients who were remote, they could see a local physician, have that checked without still having to make the long trip to Washington, D.C. from where they were. So we actually think this had a positive impact on our patients' health. Like I said, you hate to have a viral pandemic to do this with, but it really seemed to help out. The other thing that happened is we improved our access. When we had patients coming in, our average wait times for new appointments were about 60 to 120 days. And for a United States genetics practice, Jose can confirm that's actually not horrible. We have been running consistently from 5 to 10 days since that time, though, because with telemedicine, we were able to actually see more patients and also clean up some of our wait list and wait times. So what have we learned so far from doing this? Our ability to pull an extended family together in a virtual visit is better. I don't know how many of you have been in a crowded room where you have 5 or 6 relatives and it gets kind of uncomfortable for everyone. Actually, when we do this by Zoom, we can bring the families in from their individual homes and actually have a more structured conversation because you can actually determine whose microphone is turned on. When we had separated parents, many of our families are military families, and one spouse would be deployed overseas. We were able to actually have them both in for the same visit. Higher frequency for complex patients, we think definitely was a big plus. Teaching ended up also benefiting from this. We actually flipped very quickly to bringing in the medical school classes, the residents, the fellows into these learning environments here. And the reports back from the students were that this was almost as good, or in some ways even better, than when they were in the room with the physician, because normally they're stuff to the back of the room in the corner. Here they were up front where they could see the same thing we were seeing. Dietitians were better able to manage patients sequestered at home. And here was another interesting thing. So we'd noticed some of the medical teams had some decrease in morale. People were feeling stressed and tight. What we did is we actually had a meeting every morning for the entire team. We called it sort of the make sure everyone is awake meeting. And I at least know that everybody from the waist up was wearing something, so they're at least wearing shirts. What they had on below, I don't know and I don't want to know. But what we found is that actually helped improve morale. And actually, we saw more of each other this way than we would normally have if we were just all in our separate physical clinics. The big drop in no-show rates we thought was very good, and patients who otherwise might have been at higher risk, we were able to see in the wait times. Now, abnormal newborn screening was a surprise because historically, we have always said those patients must come in, we must see them, we must get them come right away. And what we did is actually we broke it down so that all of our patients who had to come in because they were at high risk, like a risk for an organic acidemia, a risk for a urea cycle disorder, we made sure they came in physically. But patients with galactosemia caught by newborn screening, by tinidase deficiency, diseases where we could immediately start treatment and monitor the patient remotely, we actually were able to do that. So we had fewer of our newborn screening patients having to come to the hospital, and we were actually able to see them sooner. So within an hour or so of being contacted by the newborn screening laboratories, we can have these families on camera, have them seen. If they just needed to get a quick physical exam from someone, they could go locally to their doctor rather than driving several hundred miles. Obviously, though, there are a few things that you just can't do that way because the laboratories aren't available, like the organic acidemias and urea cycle disorders. But that actually was a very big positive for this. And going forward, we're going to try to maintain that model. It seems to be a lot easier on the parents, reduces some of the stress of waiting to come into clinic. So that was kind of a plus. This just kind of shows what Children's did in general during the first month. We were actually, although we're not the largest division here by any shapes, we have 13 geneticists in the group, but we actually were the third largest as far as volumes go. And we got a lot of feedback from the patients. We found that they appreciated the service. They thought they were better informed because we could take our time to really talk with them. We could actually also pull their local physician in for the visit for some of these. So it actually improved that continuity of care going back to the community. It just really, and it actually was kind of fun doing this. I think we found the technology to be somewhat useful, and we found that it worked very well for the patients. So the other thing we did is, how did we handle our inpatient service? So now I'm done with my slides there, so I'll back off from those and stop sharing here. We'll go back to screen. So how do we handle inpatients? What we did is we had one physician do all of the inpatient visits face-to-face. So we'd reduced exposure for the rest of the staff. So that person was me. And Dr. Regier saw all the outpatients who had to come in, the newborn screenings, our patients with infusions where they had to get the infusion at the hospital, couldn't get it at home, things like that. And it actually worked very well. So we had the on-call team, the regular on-call team at home, taking all of the phone calls, working in the medical record for the charts and everything. And so my job was to go around and physically examine the patients in the house, make sure things were getting done properly, that sort of thing. And we did that for, gosh, 17 weeks. And it was actually quite sustainable because at night, I did not need to come into the hospital unless there was an emergency that required physical presence at the bedside. And our on-call team was able to manage those patients, working with the intensive care units and the emergency rooms. So it really was not just a horrible thing to do. As a result of that, we had nobody in the program infected, and that includes all 40 of us in the program here. We also noticed we had a very low infection rate in our patients as well too. So we think that decreased exposure rate probably kept everybody healthy. Of course, it means we still need to either get vaccinated or we're all going to have to get it at some point in time. So we'll see what happens with that. Let's talk about effect on mortality and morbidity. We didn't see a spike in admissions from our patients with COVID. We were anticipating that. We were anticipating that our organic acidemia, our urea cycle patients, our mitochondrial patients, that we would see a large spike, and we actually anticipated we might lose many of our patients. I'm happy to say we didn't. So as of now, even though we've had a lot of patients who are COVID positive, we've only had 4 patients die during this period of time who had COVID. Now, let me kind of define what I mean here. These are patients we anticipated we would have lost anyway. They had very serious, probably near terminal conditions. COVID was the virus that tipped them over the edge, but it would have been influenza or rhinovirus or RSV, take your pick from that. So none of these were patients who we would have anticipated losing, except for one who had some very unusual pulmonary findings. And they're still investigating that case. And we have found some unusual findings around vasculature in our non-metabolic patients, but just in our intensive care unit in general. There are some segments of the population that appear to have a much harder time with COVID than the others. So there's a couple of publications on that now, but it's almost like a vasculitis type picture or an ARDS picture for the adult physicians out there. So those are the things we've learned so far. I would love to get your feedback. So, and if you can share what you've learned with me too, I promise to steal your best ideas and use them up here. So Jose, I think we're ready for the next segment.
All right. I'm bringing up the questions here on the screen, and we have several for you. Thank you for your presentation, Marshall.
Pleasure.
As usual, you are ahead of the game. We were thinking about doing telemedicine at the time you were already doing it. And even though now we have adapted and started very quickly, definitely you were ahead of the game.
Well,
So,
we've been working towards it for several years. And
yeah.
so we had all of our standard procedures in place. We knew what the regulations were. And so in February, we just made sure everybody had a good computer and a good internet connection at home and a camera. And then we're set to roll. We're able to flip in 24 hours. But I've been following what you've done. You guys flipped very quickly too.
We have so far. So the first question I have here on the screen is, what sort of ethical problems have you had implementing telemedicine from the point of view of privacy of the patients, as well as any need for any particular qualification for the people who are participating on the sessions? And also, have you had difficulties with reimbursement for the telemedicine, and how is that working?
That's 5 questions, but let's tackle them one at a time.
Correct.
The first one is, from the ethical standpoint, we actually developed a short consent for the families. So we actually, we had both a video and an audio in English and Spanish saying, you will be having a telemedicine visit. Here are the issues around that. And the families had to agree that they wanted to have a telemedicine visit. And any family that did not want to be seen by telemedicine could come in for a face-to-face visit, but we found that almost everyone wanted to do that. The next is the platform. So in the United States, we have what is called HIPAA, which, Jose, I know you're very familiar with. I don't know if our colleagues are, but it's basically a very high wall at which patient information must be protected. So the software systems we used was the Zoom Medical program, which has HIPAA, and they did waive the privacy requirements around software for the crisis, but we decided to go ahead and use the advanced systems that had the HIPAA protection. We'd actually been working with Zoom for some time before this. So we had actually already tested out the system pretty well on that. The other thing we found, and just some tips for those of you using Zoom, make sure that you use a Zoom program where someone does not get into your conversation until you let them in from what is called the waiting room. That will prevent what is called Zoom bombing, where someone will come in and display all kinds of things. One of my colleagues was doing a lecture and did not do that, and they had a very interesting lecture with some movies that they'd probably just as soon not have seen. So there's a number of platforms out there. Zoom, WebEx has a platform, Microsoft has a platform in this that all seem to work very well. Your local medical EMR and IT. So our Zoom is actually integrated with our electronic medical record and scheduling system. So it schedules the visits, sends out the invites to the families with that, but we went ahead and called ahead. So the next question is, how did the families deal with this, and were there problems with the technology? This is where our medical students came in handy, and a place you might use them as well too. We had the medical students act as spirit guides for the families to make sure that they had the right software loaded on their computer, that they had the right connection, and then would sit and work with the family up until the time of the visit to make sure things went smoothly. And we had very few failures as a result. What we found is actually camera phones were the best. iPads and tablets were equally good. Desktop computers not as good because you can't follow the child around and see them, but the camera phone. So I would say this is a case where the selfie generation has benefited us all because the cameras have improved so much on cell phones that they were quite adequate for getting high resolution pictures. The other thing we did though is when we needed a very high resolution picture of something, we would have the family take the picture to show them what we wanted the picture of, take that as a still image and then send it to us. So let's say there was a rash or a physical finding that we needed more than just the video capture, we could do that. Now, reimbursement's the other issue. And our normal reimbursement rate runs about 48 to 54%, depending on the time of year. The federal government basically declared that they would treat a telemedicine visit the same as a physical visit for the same charge level. Our reimbursement rate has actually been identical with what it was before. So we've got the same, our reimbursement rate's, just around 50-ish%, and we maintain that reimbursement rate. So from a financial standpoint, our division did okay. The hospitals here, and I'm going to make the assumption they have there, have taken a beating because of so many of the cases. Elective and pediatric means repairing congenital heart disease, spines, things like that. They have taken a beating. We are probably one of the few bright spots on that. Since our specialty is mostly thought, not procedural, we did not have to cut back our patients during COVID. Next question.
So before the question, just a comment. You've been doing telemedicine for a while. For us, it was a new experience. And I found it really very humbling to get into the houses of my patients and see everything they are doing, the way they are handling a very complex patient. Sometimes I find that the patient's room is an ICU setting, basically. And it really brings you to a level of reality that you probably should have known, but you don't see it every day, and you don't realize how complicated it is to take care of home without nurses, without respiratory therapies and all that.
Well, it also gives you an appreciation for what you do to those families when you tell them to come in for sometimes not a very important visit.
Exactly.
It's like packing up an entire hospital and bringing it with them. So I think going forward, we will probably try very hard to not bring anybody into the hospital any more than we absolutely have to. Yeah, the social visit's probably a thing of the past, where you come in and say hi because you just want to say hi to the family once a year.
The other thing I wanted to confirm is the fact that the iPhones or any phone has been the best tool. And few families, really very few, didn't have the technology to do it. And we don't have medical students, but we have repurposed the people who normally take care of registration and taking the vitals in the clinic, and all of them are in charge of coordinating the telehealth, getting the email, calling the families ahead of time, being sure they didn't have any technical problems. So it takes a little bit of creativity to re-establish some roles and make everybody useful and be sure that everybody keeps his or her job. So we go to the next question. I think you addressed it, but I am going to ask anyway. Have you seen more complications because of COVID in metabolic patients? I think your answer.
My answer would be that we expected it, but we didn't see it. And like I said, we saw almost a 20% decrease in patients requiring admission. So if anything, our patients were healthier.
It has been exactly our experience. So there is a question about shipment of samples. I would imagine laboratory samples from patients to laboratories. How has that been working?
Yeah.
I would imagine that includes the availability of outpatient labs. And there's a separate question on the same topic about distribution of special products, formulas, etc., with the restrictions.
Okay, let's start with laboratories. So we actually work very closely with our blood drawers or our phlebotomists here at Children's. They took what I would call sensible but not ridiculous precautions. None of them became infected during this period, which I thought was quite interesting. So evidently surface contamination is not as bad as we originally feared. It is much more from a respiratory standpoint. Of course, they wear face shields, things like that. I would definitely recommend those. The processing of the samples beyond that was pretty routine. You handle blood always like an infectious agent and continued to do so. For patients where we're trying to keep them at home, we try to use blood spots wherever possible. So we mailed out a lot of newborn screening cards to get blood spots back on. We were fortunate we had the capacity to run those. For DNA samples, we actually converted over to using spit and cheek swabs. So we would mail the kits to the patient's home. They would swab, send it back in, and the quality of the sequence appears to be just fine with that. So the technology there has advanced enough. So that was the case. What was the last part of that question?
Regarding the shipment or supply of special products, formulas, etc.
So the other thing Dr. Regier and I have been doing is running a taxi service for formula. I think I've delivered several cases of Argo cornstarch to families. We even actually delivered a refrigerator to one family because they didn't. During extraordinary times, you just do things a little differently. So we actually got out and made sure they drove. Sometimes some of our physicians would come by and pick up a case. We'd run a case out, drop it in somebody's trunk, either the family or one of our providers. So we definitely broke down some of the classic roles. You know, my classic role is not driving a taxi. I'm good at it, but that's not my classic role. So I think one thing I would highly recommend is be very flexible.
That's wonderful. I would add that the majority of the formula companies have also been very good in helping our patients.
Yeah, direct shipment, they've been very good about that.
They've been very good in supplying to bridge the gap when the families run out of formula. Even pharmacists have been doing a great job trying to
Yes.
help patients.
We also found a few of our families who had been what we used to call the Friday night emergency. They actually got much better about that. I think the whole thing kind of focused them somewhat, and they were actually good about calling earlier.
The next question is, if you can comment on the difference between the first visit versus the follow-up controls and the use of telemedicine. When you are considering a rare disorder, how do you do a telehealth visit for the first time?
Well, first off, let me be clear. I don't think for a new patient or even a follow-up that it's completely the same doing a telemedicine visit versus an in-person visit. But we maintain the same ratio of new patients and follow-ups in our telemedicine program. I looked at the diagnosis rates. That was kind of the only objective thing I could really pull, and they seemed to stay about the same. So we were diagnosing about the same percentage of patients as we were before. Some of that's probably because we're in the new molecular age, where it's, not this disease because I say so, it's this disease because I tested the DNA and that tells me what it is. So some of that is, I think, just the evolution of the field. Some of it, though, the history taking really didn't change. In fact, if anything, the history taking may have been better on this because we often could have more time for doing things. physical exam, we were capturing more images, which may have actually been more useful than trying to chase a running child around an exam room. We were actually able to get pretty good imagery on that. Obviously, things like listening to the heart, you know, palpating the abdomen and things we could not do. So I would say it was a trade-off in that standpoint. So for our new patients, the diagnosis rate stayed about the same. For our follow-up patients, I would say it was an improvement because they were able to have less burden on being seen, which meant they were more likely to show up. I think also the fact that everybody was locked up at home meant they had nowhere else to be anyway, so they might as well do their genetics visit. So I would say with the quality of those visits improved. Would you agree with that, Jose?
Yes, but no regarding the first visit. We have not taken telemedicine for the first visit. We still do those personally, mostly because of the importance of the physical exam, unless it's a patient with a known immune or suspected immune deficiency or tracheostomy or a problem like that. But everything else, everything that's a follow-up, I fully agree with you. It's been particularly useful, I would say, with the PKU population, for example.
Oh, yes, they love it.
All the patients who are on Palynziq, for example, we have weekly monitoring and checking with the patients that we didn't have before. The same with the fragile urea cycle defects and organic acidemias. It's been a plus.
Yeah.
Also, the neuro exam, even though it should be limited by telehealth, finding the kids in their own environment and seeing them, you know, how they walk, how they run, if they can climb or not, that has been more useful than at home. Of course, you cannot take the reflexes, but besides that, it's a good, really, environment.
We're fortunate we have a very large neurology program here at Children's. There's about 45 of them. And they've actually worked out a sort of home neurologic exam kit for the families. So they tell them, here, take a picture of them doing this, take a video of them doing that, get them to do this, show us the pictures of that. They couldn't get the reflexes. That one's still a skill set. But actually, almost a better neuro exam than you'll get in clinic when a patient is upset.
Yeah.
All right, what else we got?
We, knowing that you really do a lot of research, how the crisis, the pandemic has affected your clinical studies, your research, and the possibility of recruiting patients for trials or follow up those patients on trials?
Well, what I can say is that's probably been one of the biggest impacts, because clinical trials, particularly for a new therapeutic, are very rigid things where the expectations are patient comes in, these things are done, and very quickly what most of the studies found is that we have these things called protocol deviations. And they were just at first going nuts. The sponsors for the studies went nuts over the fact that suddenly the patients weren't coming, or you couldn't do certain things with the patient, things like that. And very quickly, the FDA and the companies realized that we're just going to have these protocol violations. But as long as we could get our core data set, so we had 2 studies that went on hold, which is unusual. And after about 2 or 3 weeks, when they worked out the logistics, you know, went back to the regulatory agency, said, is this okay? They actually were able to move forward with doing that almost completely by telemedicine. So the problems, the ones we had the most trouble with were patients who needed frequent blood drawings. Just coming in for the exposure for that was an issue. We were still able to do some of those studies, but it required a lot more organization to do that. So I would say there was a heavier, for us in our program, there was a heavier impact there than there was on our routine clinical visits.
Yeah, I also want to add that suddenly the hospitals became a very safe place. Our waiting area is very, very, very space, and you rarely have patients even near each other as it used to be. Every patient and family screened. Only one parent is allowed to come into the hospital with the child, and they are roomed immediately. Even we have a system where if there are many families waiting, they are waiting in the car in the parking lot, and we call them as the room is ready for them to be placed. So we've been very careful in trying to minimize contacts, and so far we haven't had major hiccups. So one question here. Yeah, sorry.
No. We came up with a couple of suggestions for our families who are coming in. One of which, since almost all programs now have done so, only one parent can be in a hospital room with a child. The other parent is, Jose said, is stuck somewhere else. We told them to bring more than one charger for their phones.
Yeah.
We actually found that. We actually went and cleaned out one of the stores for all of their chargers and distributed them to families one night because our families were suddenly separated with dying phones. The other thing is, since many hospitals are diverting pediatric patients to other facilities, we strongly recommend that families bring their medicines with them to the hospital, because if they're going to a hospital that's not used to taking care of them, that can be a real problem. We also tried to make sure everybody's treatment sheets were up to date, and that the families felt very comfortable calling us if they ended up in another hospital. We did some work on this with NORD for sort of the rare disease community in general, but those were a few things we learned that seemed to help some of the families out.
So do you think, one of the questions from the Dr. Mahfoud, do you think telemedicine will continue a couple of years from now?
Well, I do. So it's like a rubber band. You stretch the rubber band out, and even if you completely let go, it doesn't always go back all the way. So I think if we did nothing, there would still be an increase in telemedicine. I think certainly the lessons learned are going to increase. However, I think our field is very well suited to telemedicine. Ours is not a procedure-based field mostly. Ours is a thought field. So our patients actually can benefit sometimes as much from seeing and talking to us as by us laying hands or cutting something open or putting a cast on something. So I do think this is going to be a permanent part. In my program, we actually went through and surveyed all of the physicians, and we also surveyed our families. We will have a minimum of 30% of our visits by telemedicine going forward. We're fortunate in the fact that as a thought specialty, we don't generate a lot of revenue for the hospital, so they leave us alone for what we want to do to see the patients. I don't know that that holds up across Latin America or not. I suspect it might, though. And so we have, I think, in some ways, a little more flexibility on how we see the patient. So I think, like I said, maybe 30% is not an unreasonable number. I think, as you said, and it's for targeted patients. I think new visits are still probably best in person, so, whenever possible. But for follow-ups, I think many of those can be done by telemedicine.
Yeah, I fully agree. What we have so far decided is that at least once a year, the patient has to be seen in person. And then everything else can be telemedicine in terms of follow-ups for the population that you mentioned. But we are still learning us. So there's a question about what have been the negative aspects of telemedicine besides the physical exam?
Beyond the physical exam, when you have to deliver bad news to a family, there's not a complete substitute for sitting with someone next to them and telling them what is happening. That's one of those things where being there, sometimes being able to hold someone's hand or to talk to them, there's not a great substitute for that. The other side of that is having someone in a comfortable place in their home, oftentimes with their family around them, can offset that some, but that was one negative. Another was some families had trouble with the technology. Actually, some of those people were one or two of my doctors. I have some doctors for whom technology is very easy, and some doctors for who it is not. And so the quality of the, no comment. The quality of the internet connection could play a role in the quality of the visit. I don't normally, when I'm seeing a patient face-to-face, freeze in the middle of a conversation, but we would have times when the video would freeze or the connection would freeze. So I think some of the technical issues, some of those times when you really want to be with the family, those were some of the negatives.
All right. The next question, and we have about 10 minutes, actually 5, regarding medical education. You do a lot of teaching in pre and post graduate programs. Have you been using these technologies? How do you see the use of this technology in the future in education? And I think this is an example of what we can do, but your comments.
So I think you probably know the answer to this one, Jose. It actually, at first, everyone didn't know what to do. I'm fortunate that my colleague down the hallway is a gifted educator and immediately started pulling the residents, fellows, and teaching, and we actually brought them for their clinical training, into the telemedicine visits immediately with good success. Actually, they seem to learn a lot. The physical exam issues, obviously, we have to put off a little bit because we still need to teach them that, but that's going to come later. But they learned a lot about how to interact with patients, because in some ways we had them actually talking to the patients more than we did. They were in bed with the family. They got to see what it was like in the home for those patients. So they learned things that might have been good for us to learn when we were medical students. They learned kind of how to do these things, how the families adapted, how they cared for very sick patients. From a lecture standpoint, we observed two interesting things. One of which, it was very easy to take roll call on who came to the lecture. And it's like, I know there's 134 people watching this right now, and it was 190 a while ago. So a bunch of folks went to get a coffee. But also, in any lecture hall, the people sitting in the back tend to not get as much of the instructor's attention as the ones in the front do. And what we found is by putting everyone on that vertical wall with all of their images exactly the same size, there's no place to hide. And you could also much more easily call on people to contribute, particularly when you could mute the ones that were always talking over someone else. Deb was successful enough at that where she won the Educator of the Year award at NIH. She's actually written an article about education in the time of a pandemic, which if you want, once it comes out, I'll be happy to share a copy with you guys on that. But the students, the trainees actually seemed to feel it was a very positive experience.
Wonderful. Do you think that we'll ever go back to normal? I think we were talking about the prevalence of telemedicine beyond the pandemic, and I think to make it short, we learn a lot of things that we probably should have applied every year at the time of the flu season that we never did, and now we have to.
I think, and like I said, I would not wish this pandemic upon anybody. It's had many horrible things, but there have been some positives that have come out of this. Our payment and structure and clinical systems were such that I don't think we were providing what I would call the absolute best care for our patients, the one that was the best for them. And I think this forced us into changing the model. And I think if we are smart, we will take some of these lessons forward, exactly as you just said, Jose. We will manage more things on follow-up by telemedicine. We will work on things that keep our patients in a safer place when that's where they need to be. And I absolutely agree that we should increase the use of telemedicine during flu season. We should keep patients away from the hospital. We should try to make sure those visits where they need to have the physical contact, try to do those in the off seasons for that. I couldn't agree with you more on that. I think, and I guess what I would say is the normal that we were doing was not necessarily the normal that was best for our patients. And I think this gave us an opportunity to do some things that otherwise were very hard to do because of administrative blocks, financial blocks, things like that.
I'm gonna take the last question, which is important, tell you about the last question, is regarding vaccinations at the time of the pandemic. The question is placed about any particular vaccine that you should or should not give to our metabolic patients during this time. But I think the second part should be of at least has in our experience. What are you seeing in terms of vaccination in the general population?
We're way behind. Since people have not been going in to get their routine vaccinations, this has been a real concern. I know in California it's been an issue. Here on the East Coast it has been too. Since families aren't going in for regular pediatric visits, vaccinations are behind. I think we'll probably start seeing sort of vaccination vans going out to help neighborhoods get caught up on their vaccinations, things like that. Kind of like what we used to do with the public health department here many, many years ago. So I'm hoping they'll get caught up. From the standpoint of what vaccinations to give our biochem patients, that actually to me isn't so much an answer about COVID as long-term management. And my answer is always all of them. We did a study with Kaiser Permanente where we looked at somewhere, I think, around 100,000 vaccinations into their biochemical genetics group. We published this about 10 or 15 years ago. And then we looked to see whether there increase in hospital visits, ER visits, or illness after receiving a vaccination in that 21-day window afterwards, and there was not an increase. So I think the vaccinations are safe. You obviously take some precautions. Kids react to some vaccines, but the effects of the diseases on those patients, if they got them, would be devastating. So I hope we'll get caught up on our vaccination program pretty quickly.
All right. Well, I think with that, we complete the questions and answers. I'm going to try to share some thoughts at the end. Before doing that, our big thanks to Dr. Sumar, who I don't know how he does it, but he has a level of wisdom that applies to each and every situation, even the most challenging ones. Thank you so much. So I'm trying to share my screen now. Let's see how it goes.
Jose, I would say the same about you, and I've known you many years.
Thank you. And let's see how this works now. Let's see.
I would have put you in our remedial technical class here in our division.
I need it. Okay. I hope I'm sharing my screen right now. Okay. So as Dr. Sumar mentioned before, with a quote from Winston Churchill, this is not from him, but it's very similar. And with every challenge, there is an opportunity. We can all blame the pandemic for what we are going through, and there are plenty of things to blame the pandemic for, but also we can look at it as an opportunity for many things. There is an opportunity to be, and my animation slide is not working. So let me see what I can do. Now, there is an opportunity to be a better leader, and we definitely heard that from Dr. Sumar. I learned a few things. I used to start my meetings with, okay, what new patients did we have, or what problems did we have this week? And I start every meeting now with the question, how is everybody doing? and we don't do it weekly. We do it weekly, not daily, as Marshall does, but definitely that's a must these days, and trying to understand what people are going through. You need to adapt. You need to repurpose your workforce, and you need to try to be sure that nobody loses his or her job, because that is really happening in healthcare, which is a paradox, thinking that we should all be very busy at the time of a viral infection. It's a good time to help others also to navigate the crisis, and that could mean friends, could mean neighbors, or could also be your teammates. Some of them may have lost family members. Some of them may have elders that they are trying to care for. You need to be flexible. You need to help them and understand what challenges they are facing every day. It's a wonderful time to finish projects, those projects that you never had time for, those guidelines, those papers. Start the draft of your new project. Begin thinking about the next meeting in Australia, the international one that's going to be, with us as soon as next year at this time. Think about the potential sharing your experiences, even regarding COVID, with the medical community in your city or in your country. So there are many things that we all have that we never have time for, including family projects, including hobbies, but find time to do things that will make you feel good about this time that appears to be endless. Spend important, valuable time with your family. That does not mean being in the same room watching TV, means doing things together, really sharing stuff with each other, reviewing old pictures, doing some project together. Reach out to friends and families who are far away. I have most of my family in Argentina, and it's been a wonderful time actually to be in touch, because everybody seems to be having more time, even though I don't, but everybody's sharing experiences, pictures, and we laugh frequently. So try to continue doing that. Play with your pet. That's exactly what I'm doing in the picture. We rescued her recently, and that's the best thing you can have at home, a pet to play with. They are fun, they are never downbeat, and they will keep you happy all the time. And finally, depending on your age, you also may want to think, how would you like to leave this planet? We are not going to be here forever, and some things have to be dealt while we are here. So with that, I'll give it back to Maria de Jesus.
Okay. First, thank you, Dr. Sumer and Dr. Abdenur for this conference. I think was a great experience for all the participants. Okay, and now in español continuamos y les agradecemos a todos su participación y los dejamos invitados para el seminario web que se realizará mañana 16 de julio a las 16 horas. Este es titulado con Bioseguridad y Readecuación del Laboratorio de Pesquisa Neonatal y Enfermedades, y Errores Innatos en Metabolismo en tiempos de COVID-19. Estará dictada por el doctor José Cocho y moderada por el doctor Gustavo Borrajo. Ya no les quitamos más tiempo. Muy agradecidos de toda su participación y nos vemos mañana.
Drink with me, raise your glasses for toast to a little bit of chicken fried. Cold beer on a Friday night, a pair of jeans that fit just right, and the radio